So I wanted to wrap up this series of videos just by talking about general selection of treatment and then just going through a case. So things to think about when you're choosing a product for management of ADHD. In most cases, we're going to try to look for an appropriate stimulant. So stimulant whenever appropriate. So thinking about those contraindications. But then we want to know, especially if it's a pediatric population, how they are with pills, right? So if they have trouble swallowing, there are liquids, there are chewables. Some of the capsules you can actually open and sprinkle into things like applesauce. There are patches. So choosing a formulation that matches the needs of the individual. Then, of course, affordability and sadly, availability. So sometimes these products, especially with the really increase in utilization of stimulants, largely for good reasons, this increase of utilization of stimulants can cause strain on production. There's oftentimes a lot of pieces that go into it, but there are limitations as to how much stimulant can be produced by a drug manufacturer. So when a controlled substance is produced, part of the process is obtaining product and approval through the Drug Enforcement Agency. And if the manufacturer actually reaches their limit of how much they can make in a year, then sometimes that can be difficult for them to get approval for creating more product, right? And we've had some products that have transitioned from brand to generic. And oftentimes during that transition phase, there's some disconnect with availability, with, the brand starting to become less produced and the generic becoming more available. Insurance companies can sometimes get behind or even ahead on coverage where they may not have transitioned their formulary to the generic, or they transition their formulary too early to the generic before it's available. There's a lot of different reasons why there can be supply challenges with products. So just being aware of that as a potential issue that you might run into sometimes. And then thinking about daily dosing need. So long acting, if coverage is needed throughout the day, some people may not need a full day coverage. For kiddos, sometimes it is better to try to get them on one product that they can take either the night before for things like Jornay or first thing in the morning, so that they don't have to go to the nurse at school and take a dose during the day. And think about coexisting conditions and how to monitor and check for potential worsening or changing of those conditions. And then, of course, sadly, abuse potential, right? So screening for appropriate use, keeping in mind that sometimes it's the family that can be diverting products. So I want to finish this off by talking about a case here. So we're talking about this case, MJ. So MJ is a 6-year-old female, and the 6-year-old female has a history of allergic rhinitis, no other significant medical history. She presents with behavioral complaints, so inability to sit quietly during activities, difficulty following directions from adults, problems with peers, like waiting for her turn, respecting personal boundaries, getting a little bit too touchy and invasive with other individuals, speaking over others, poor spatial awareness and judgment, but no significant academic problems. Pretty bright kiddo. Now, we do see more underdiagnosis of ADHD in children who are female, because they tend to have a little bit less behavioral kind of components, a little bit less of their impulsive stuff. They tend to be a bit more on the inattentive side, but this individual is showing both types of symptomatology, right? So the parents were concerned. They are having trouble keeping the child in daycare. They had behavioral problems during kindergarten. The child of note completed occupational therapy at age 4 for some sensory processing integration and did well with that. Had a Vanderbilt score, which is one of the more common children's ADHD scores, which scored high. And some of the rule outs that I think are really important that we do. So things like conduct disorder. I'm going to turn off my camera. Conduct disorder, anxiety, because sometimes that can look like ADHD, depression. So we screen for these types of things as well. So what type of intervention and monitoring would be appropriate for this particular individual? So the first thing you want to think about is age. So 6 or older, this individual is 6, so they would qualify for medication treatment as a first line option. From there, we go stimulant, right? So stimulant, typically methylphenidate is going to be your first stimulant for kiddos. Not always, and there's reasons to do other ones as well, but by and large, stick with the methylphenidate first. Get just less side effects associated with it. It's a more specific mechanism of action. If we start a stimulant, we also are going to recommend things like the non-pharmacological interventions. So classroom management, the parent psychoeducation, the parent psychotherapies. And then from there, we want to think about what baseline and monitoring we would do from there. So we can start with something like a low dose of long-acting Ritalin, for example. Okay. And we would make sure that we have a clear cardiovascular family history. We want to make sure that we're aware if they have any tic disorder, seizures, anything like that we would need to monitor for. Starting at the initial dose and titrate up, usually at weekly to every 2-week intervals based on response and tolerability, with usually in the first month follow-up to assess for things like vitals, changes in appetite, sleep, etc., right? And of course, benefit. Once you've gotten your dose, gotten your product, then we're still going to be monitoring our growth curves. We're still going to be monitoring our vitals, right? We're still going to be checking in for improvement over time. And once the individual is doing well, we can often go every 6 months, but 3 to 6 months, especially if they're younger, you may be a bit more cautious about it, right? So this particular case has been through a number of different stimulant type products, generally does pretty well with stimulants, had some issues with availability. It was on Concerta for a while, ended up on Daytrana for a while, ended up on Jornay for a while, which assisted in doing well in the mornings, which was great. So other things to think about, really, when we consider holidays with medications, right? We want to think about symptom severity. This individual, if their Vanderbilt is doing a lot better, maybe trialing off for a period of time during things like the summer to see, as they get older, those kinds of things. And offering continued non-medication options. Now, caveat, one non-medication option that I didn't really spend much time talking about, there are digital therapeutics as well that can be available for ADHD management. Particularly, it's called Endeavor, which is a video game. So there's an Endeavor prescription for children and a over-the-counter version that you can purchase for adults as well. So those types of things can sometimes be incorporated as well. So that is it. If you have questions, you know how to reach me, either here or an email or what have you. ADHD is simple but difficult a lot of times. The treatment is fairly straightforward, but the variety of products that are available, the monitoring of adverse effects can pose quite a challenge. Not to mention some of the risks associated with those products, unfortunately, can make it more difficult to get the products and get them consistently for your patients. But that's all I have to say about that today.